I'm Eric Bricker, and I've been a psychotherapist for over 25 years. One thing I can tell you for certain is that no one makes it through life unscathed. At some point, many of us will rely on the trusted counsel of another person to help us navigate difficult times, or to reconcile a troubled past. Whether conventional or unconventional, professional or informal, there are a lot of different forms that helping relationships can take. This podcast is an exploration into what makes these relationships work. Who are the people that help us? How do they help us? What do people need help with? My hope is to uncover as much as I can about this very human phenomenon, and I hope that you'll join me. This is the Good Counsel Podcast. I'm Eric Bricker, and this is the Good Counsel Podcast. Today I'm going to be completing the second installment of my two-part series on prolonged grief disorder, which was material that was taken from a lecture that I completed in 2024, a little over a year ago, for an audience of other therapists. So it was like a continuing education event, and now I'm recording this information for the podcast. There were actually some people that I talked to after the fact that said they would like to have attended and they were unable to come. So I would like to make this material available for those folks and just to have it be part of the podcast library, since we didn't record when I completed the original training event. In March of 2022, the American Psychiatric Association included the diagnosis of prolonged grief disorder into the Diagnostic and Statistical Manual of Psychiatric Disorders, the 5th revised edition. So I talked a little bit more specifically about prolonged grief disorder in the last installment. And this one, I'm going to go a little bit more into the interaction between prolonged grief and substance use disorders. The interaction between grief and substance use disorders has long been discussed among treating professionals, and the addition of prolonged grief disorders into the Diagnostic and Statistic Manual now provides more specific diagnostic criteria. So this is really good. It allows for greater research opportunities about comorbid substance misuse and prolonged grief, in addition to discussions about the concurrent treatment of both conditions. So if you have this criteria now for what separates prolonged grief disorder from a regular grief experience, or what would be within the normal range of grief experiences, we're able to talk about the outliers here of complicated grief. Now you have the specific criteria that allows you to have more scientific discussions, say. So there's research that can be done, and we can look at the unique interaction between grief and substance misuse that professionals in our field have long discussed, because we know that it exists, but we didn't have a specific scientific body of knowledge or peer-reviewed journals or research materials to support our ideas. So it's really more anecdotally based, what the previous discussion has been. And now we can do it in a little bit more of an educated way, which I think is a good thing for the field, people who are working with individuals with substance use disorders, and looking at that intersection between complicated grief and substance misuse. In order to have an intelligent conversation about prolonged grief disorder and substance misuse, I want to take a little bit of time to make the distinction between what is normal grief and what would be considered complicated grief. Researchers at the New York School of Psychiatry in 2021 published some significant research to illustrate these 4 models that really kind of demonstrate for us the ranges of normal grief reactions, what would be sort of typical of the majority of the population. So after the experience of having lost someone that was important to us, losing a significant relationship, what would be the range of experiences that were most common among the largest segment of society? So the researchers at the NYU School of Psychiatry came up with 4 basic models that included the largest segment of society. I'll go over those really quickly. So the first grief model shows that 26% to 45% of people will experience stable to low levels of grief symptoms over a trajectory of 1 to 3 years post-loss, and the experience that they will have is largely based on other factors, cultural factors, the significance of the relationship itself, and the circumstances surrounding the loss. So all of these different factors impact how these people will experience grief. But basically, these 26 to 45% of people post-loss will fall into this first category of stable, low levels of grief symptoms. So not really making a huge distinction between the acute phase of grief, where the symptoms are the most severe, and the integrated phase of grief, where the symptoms are much less severe. It's more indistinguishable, the really bad part from the integrated part of moving forward. The next group, which includes 30 to 33% of people, fall into this moderate levels of grief symptoms. So it might vacillate from moments of more severe levels of disturbance and then moments of less severe disturbance, but they're going to kind of fall into this moderate level where there's going to be some degree of difficulties, managing their grief. And again, the trajectory, the period of time is going to be 1 to 3 years. The third model includes 16 to 20% of people, and this is the high level of grief symptoms post-loss. So these are people who are having a really tough time, but don't fall into the prolonged grief disorder or complicated grief category, because even their high levels of grief symptoms and what they're struggling with, really having difficulty adapting to the loss, doesn't fall outside of what might be considered a normal reaction to a significant loss. And then there are 10% of people who experience the delayed onset of grief symptoms, which means that the symptoms, the difficulties that they have post-loss, don't start until some period beyond the loss itself. So these people are beginning to struggle at a period of time after the loss, and that could be a few weeks to a few months, and sometimes even years after the loss before they start to demonstrate symptoms of the loss. The majority of individuals will move from the acute phase of grief, which is the more difficult period associated with depression and difficulty kind of carrying on your normal day-to-day activities in life. They will move from this acute grief to integrated grief within 6 to 12 months post-loss. So again, the acute phase is where it's very difficult for you to maintain your regular activities in life with relationships and the things that you would normally do, maybe your job. It's hard for you to do all of these things. And the integrated phase of grief is when we have moved to a place where we've re-engaged with our regular activities. It may still be difficult. We may still be struggling on some levels, but we are able to function within our kind of normal range of functioning. So the movement from acute grief to integrated grief occurs within 6 to 12 months post-loss. And most people within the 4 models that I just illustrated will fall within this trajectory of moving from the acute grief to the integrated grief within 6 to 12 months post-loss. So individuals who fall outside the range of these 4 models and continue to experience what might be considered acute grief symptoms beyond a year would probably be considered candidates for a diagnosis of prolonged grief disorder. Here's some of the criteria. So a sense of disbelief about the loss, feelings of disbelief or an inability to accept the loss, these intense and persistent feelings of yearning for the deceased, a lot of rumination about the circumstances or consequences of death, so consistently being fixated on the way the individual died. And this is quite common in individuals who have died of illnesses, who have died in hospitals, people who have died by accidents or under these kind of catastrophic catastrophic and tragic circumstances, people who were victims of violent crimes, all of these types of traumatic losses will often lead to rumination around the circumstances or consequences of death. I think family members that have lost a loved one due to suicide and or overdose death, there is a lot of rumination about the circumstances surrounding those experiences as well. That is really quite common. A lot of anger and bitterness, experiencing this pain that the deceased person may have suffered. Hearing or seeing reminders of the deceased person causes a great deal of distress, and it may result in difficulty trusting or caring about other people, and that all of these things that are going on create some clinically significant impairment in social, occupational, or other important areas of functioning. So that last one is kind of the distinction between what would be normal grief and this prolonged grief disorder. And let me say what I mean there. So there is a level at which the grief becomes pathological, right? Where it becomes almost like a mental health issue, not all that different from like a severe depression, as opposed to our normal reaction to a loss, which could be really quite significant for a long period of time. But eventually we're moving into the integrated phase of grief where we're resuming our regular social, occupational, and other important areas of functioning. The person with prolonged grief disorder, they're not able to do that. They're not able to integrate back into their normal functions. And that's sort of the difference between the prolonged grief disorder and just difficulty with grieving. I want to talk a little bit about some of the prolonged grief disorder risk factors, which are kind of interesting to me in that they mirror or overlap with risk factors that increase the likelihood of a substance use disorder. So there's overlap here between prolonged grief disorder risk factors and risk factors for the development of a substance use disorder. And I think that that is really worthy of a close examination and probably something that could be receiving greater focus in the world of research. And I'm sure that there's some of this going on already and that there will be more as time goes on. So prolonged grief disorder risk factors: separation anxiety in childhood, controlling parents, abuse by or death of parents during childhood, a poorly functioning marriage, insecure attachment style, emotional dependency on the deceased, lack of preparation for the death, and in-hospital deaths of loved ones. Obviously, trauma, right? The in-hospital death of a loved one, abuse by or death of parents during childhood, separation anxiety in childhood. These things all kind of point to the possibility of some kind of traumatic experiences, increasing the likelihood of a prolonged grief disorder. But there's also this other element of attachment-related issues. So there's also some theoretical constructs about addiction being an attachment disorder, and this is based largely on the work of Philip Flores, whose book Addiction as an Attachment Disorder was published in 2004. So his book explores the connection between attachment theory and addiction, suggesting that addiction can be understood in part as a result of insecure attachment patterns developing through childhood. And so the idea of substance misuse is really kind of reactionary or a coping skill that develops over time as the insecurely attached child and adolescent resort to substance misuse as a means of self-soothing and managing experiences of loneliness and alienation and difficulty connecting. So the substance misuse is a means of filling the void that is left as a result of being insecurely attached. So again, interesting overlap between the risk factors regarding attachment for both substance misuse and prolonged grief disorders. And it it makes sense that people who have these insecure attachments or have had some history of difficulty in forming meaningful connections in their lives or stable connections in their lives might have difficulty managing grief and loss, and that they might be the same people that would have difficulty with substance use disorders or be at risk for either or both conditions. So, interesting research into the connection between prolonged grief disorder and substance use disorder in the Addiction Research and Theory Journal, where they compared the incidence of complicated grief or prolonged grief disorder in patients diagnosed with substance use disorders versus the incidence of complicated grief or prolonged grief disorder in the control group, the comparison group, which were individuals who did not have substance use disorders. And what was found was that the incidence of complicated grief among the substance use disorder group was 34.2% versus 5% in the control group that didn't have the substance use disorder. So what does that tell us? Well, what that tells us is that complicated grief or prolonged grief disorder symptoms are far more likely to occur in people with substance use disorders in comparison to those who do not have substance use disorders. So the likelihood of complicated grief is increased significantly by a substance use disorder. Another study out of the University of Girona in Spain examined the presence of prolonged grief disorder in their inpatient clients with substance use disorders, discovering that those that were affected by prolonged grief or complicated grief were more likely to use less adaptive coping strategy, meaning that they were struggling in a way that was qualitatively different than their peers with substance use disorders that did not have any history of prolonged grief. And so what was different was the researchers found that the prolonged grief disorder population were more limited in their capacity for emotional expression, meaning that they would either be very withdrawn emotionally or explosive, and that they were prone to social withdrawal, that they were less likely to integrate effectively with their peers, that they were prone to wishful thinking as opposed to looking at situations more pragmatically or practically in terms of evaluating the reality of their world. So if you remember when we were talking about prolonged grief disorder, how that is associated with a lot of difficulty navigating the reality of loss and accepting the reality of loss. So it looks like people with prolonged grief disorder and substance use disorders are prone to this more wishful thinking around navigating the realities of their situation, as opposed to being able to kind of deal with the reality of loss, the reality of substance use disorders. And individuals being treated for substance use disorder concurrently with prolonged grief were also more prone to severe self-criticism and shame than their cohorts that didn't have the prolonged grief disorder. So people that were just being treated for substance use disorder had less self-criticism than those with the prolonged grief disorder. And again, if you look at prolonged grief disorder and how that impacts people, there is a lot of blaming oneself and a lot of strong feelings of guilt around losses and unresolved guilt around the relationships to the lost loved one. It makes sense that the same type of issues might be complications for their treatment process for substance use disorder. I think that any of us that have worked with substance use disordered populations in the past would say that it was pretty reasonable to suggest that people with substance use disorders alone are quite capable of extreme self-criticism and shame and guilt. Also, their share of wishful thinking and not completely living in reality, that they might be prone to social withdrawal, and that their sense of emotional expression and managing emotion and their tendency towards emotional dysregulation, that all of those things are problematic in people with substance use disorders in and of themselves. I feel like what this research is suggesting is that individuals who have the prolonged grief disorder, the complicated grief comorbid with the substance use disorder, are just more prone to severe versions of these maladaptive coping strategies, that they tend to struggle in some way that is worse than their cohorts, their fellow clients in programs that are being treated only for substance use disorders without the co-occurring complicated grief issue. So a little bit more information from the research. A meta-analysis of 12 peer-reviewed journals on the subject matter of substance use disorder and complicated grief had some findings across the research. It suggested that individuals with substance misuse were at increased risk for subsequent development of complicated grief, particularly when increase in substance consumption preceded bereavement. So to me, when I hear that, I think about the opioid epidemic and what happens when a person's use of opiates has increased. They're in a progressive period of the substance use disorder where they're using more, and people around them are likely dying from drug overdoses. And while they are in this period of increased use, they're not able to process these losses, which may be close friends. There may be some sense of responsibility if I'm the person that provided these people with drugs, and I just can't really get in touch with that while I'm actively using, and then I go ahead and get sober. And now I am in touch with all of what has happened during my substance use. So I think there are all kinds of links between increased substance use and what happens as far as when we lose people during these accelerated periods of use. Another example I could think of from my own work as a therapist is these situations where friends or family members die and we are not able to show up as responsible friends and family to support the other loved ones because there's just too much substance misuse and just not able to be present for these things. So you hear about people, I hear about my clients missing funerals or just being kind of a no-show and really feeling as though they have disappointed their family members and friends by not being able to be present for them. And this results in this tremendous guilt that follows, once they realize that this moment is gone and they just simply were not able to show up. When you think about guilt and shame being a part of the normal recovery process for a lot of people, this is just an added element to that. So you can imagine how this would complicate the grieving process as well. Conversely, it is suggested that complicated grief predicted increases in substance misuse. So that stands to reason and seems pretty self-explanatory that when someone is struggling with complicated grief following a traumatic loss, that there is often the reliance on substance misuse as a coping tool, maladaptive coping tool that ultimately becomes its own problem. And then you have this comorbid problem of this grief that will not resolve itself, coupled with now pathological substance misuse, creating a whole host of problems for people. Some good news here. Grief interventions were effective in reducing symptoms of prolonged grief disorder and substance misuse simultaneously. So that's a really great discovery to be made, that treating prolonged grief disorder and complicated grief along with substance misuse is effective in reducing symptoms of both of these issues. And when I think about that, I often think about people getting sober and how being in a therapeutic community with other people, working on sobriety, maybe addressing spiritual conflicts, and having this support of a community and this other important thing to focus on is a good remedy for the ruminating, painful thoughts and isolation of prolonged grief, and will give rise to some kind of therapeutic resolution. And that's been my experience, that people with severe grief and substance use disorders, that addressing these things simultaneously is very helpful. So seeing that was suggested by the research findings is very encouraging to me, because it sort of supports and validates my own beliefs about substance use disorders and prolonged grief. And they said that the most effective models for treating concurrent complicated grief and substance use disorders include CBT, motivational interviewing, processing, and education, pretty much the standard offerings in residential substance use disorder treatment, cognitive behavioral therapy, motivational interviewing, simple processing of events, and, the utilization of support and working out one's feelings and emotions around the things that are going on in their lives, and education about the grieving process and about substance use disorders and about emotions themselves, particularly for people who never really have done a lot of work to improve their understanding of emotions and feelings and are really first talking about this for the first time while they're in some kind of treatment. So some of the larger therapeutic goals of therapy for individuals who are dealing with complicated grief and substance use disorders, or people who are just really dealing with difficulties around grief. We want to get to a place where we are able to be realistic and accept the reality and finality and consequences of loss. That's important, that we are moving through these denial and we're able to accept that this is what it is, that the person isn't coming back, and that we have to find a way to deal with this, however tragic and disappointing and depressing it might be. The second goal is to try to reconfigure the internalized relationship with the deceased person and to incorporate this reality. So the idea here is relationships with deceased individuals can continue to be dynamic. They can continue to have a life of their own if we are intentional about keeping the memory of this lost person alive and maintaining a relationship with them by keeping them in our lives, by thinking about them, by talking about them, by sharing certain rituals with other people that knew them, making sure that we're talking about them with other people that had some appreciation for these lost loved ones. All of this stuff is really important, that when a person dies, they may be physically gone, but they are still part of our consciousness, and we still maintain a relationship with them. And if we don't focus on that and make some effort to reconfigure this relationship now that the person is no longer here, then we're only going to be able to focus on this individual around the tragic loss and not what the possibilities of the future are in terms of being able to continue that relationship with our lost loved one. And the third goal is to try to envision ways to move forward with a sense of purpose and meaning and possibilities for happiness. And these are tough, when there are these significant losses, to be able to acknowledge that, yes, this person is gone and it's really sad, but I'm still here and I still have to take some responsibility for myself and moving forward with my life. And that is often a difficult thing for people, but I think it's also an important goal of recovery and sobriety. So that sense of personal responsibility for creating purpose and meaning in one's life and for moving forward and understanding that happiness and a more joyful life is possible even in the face of these tragedies. And that can be very difficult for people to wrap their minds around, but these are the goals. So accepting the reality of the loss, reconfiguring our internalized relationship with our lost loved one, and envisioning ways to move forward with a sense of purpose and meaning. All right, so that's really it for the prolonged grief disorder and substance use disorder, the second half of that lecture. I hope you enjoyed it, found it useful. For this and some of my other material, the Good Counsel Podcast, available on Apple, Spotify, Google Podcasts, and at my website, ericbrickerlmhc.com. As always, thank you for listening and thank you for your support.